Hello, colleagues. Good morning, good afternoon, good evening, wherever you are joining us from all over the world. Thank you for joining and connecting, and I hope that you will find it interesting and I will be able to share as much information as possible. I just remind that there is a Turkish translation channel for the colleagues from Turkey. And in the end of the webinar, we will do a Q&A session in the last 10 minutes. So stay connected. And if you have any questions, you are welcome to write them on the chat and we will answer them in the last 10 minutes. So today I will discuss with you the periorbital region, which is very important region, very well-known region, both for its demanding, because a lot of people demand this treatment and a lot of people want this treatment in the challenging periorbital area, but also because of different complication, different diagnosis. So we will review histology, anatomy, different pathogenesis, and different treatment strategies with energy-based device, with injectables, and of course with combination with cell booster, because the cell booster is giving us wide range of effects that we can combine and incorporate in order to have homogeneous and combined treatment. So this is my topic. This is a short disclaimer. This presentation was done by me. I will present myself shortly. My name is Guy. I'm a medical doctor practicing aesthetic medicine in Israel. I hold master degree in aesthetic medicine and postgraduate diploma in clinical dermatology. I own two clinics in Israel, but I also work in the plastic surgery department and in big health organization in Israel. And I'm international trainer for CELLBOOSTER as well as of other international aesthetic companies that you can see in front of you. So this is my disclaimer. So as I said in the beginning, I really believe that because most of my patients that come to my clinic in one way or another are asking for treating the periorbital region. Some of them complain about wrinkles, some of them complain about puffiness, some of them about darkness under the eye, and some of them just don't know what they want. They just say, we want treatment in the periorbital region. It is very common treatment to do in your clinic, and it's very variable because different practitioners, different colleagues are using different strategies in order to treat the periorbital area. Some of them are better, some of them are more complicated or more prone to complication, and we will discuss different strategies and how to manipulate them. But every time that some patient is coming to my clinic and asking for periorbital region, what I really want to tell them is that I have bad news and worse news. And what I want to hear before. Do you want to hear the bad news or the worst news before? The bad news in the periorbital area is that there are a wide range of pathologies. We cannot really know if we are not experienced and if we don't know anatomy well and pathogenesis well, what is really the pathology that caused this problem. It's true about pigmentation. We know that it's part of the pigmentation, it's hypermelanin production, and some of them is because of the shadowing, some of them is because of the blood vessel, and it can also be because of the thin skin that make the skin be close to the muscle and thereby reflecting its color. So we cannot really know why the pigmentation is. We also cannot really know why there is tear trough defect, because some of them are experience atrophy, some of them pseudo herniation. So we know that there are so many different conditions and we cannot really diagnose it so easily in our patient. And another bad news is that it might not help. Many times we are doing some treatment in the periorbital area and it does not work. And the reason that it does not work is because we don't have the correct diagnosis and we don't know how to approach this pathology. So this is why I find this area really challenging. And this is why we call this webinar the challenging periorbital area, because it is challenging to diagnose, to combine treatment strategy, or to perform treatment that will help in high degree or with high confidence. But this is not the worst news. This is the bad news. The worst news in the periorbital area is that we might have complication. We know that the periorbital is so delicate region, not only because of the thin skin, but the amount of layer is variable. The pathogenesis is sometimes including lymphatic drainage and vascular drainage, and this is why we have so many complications. We have complication with just common treatment like botulinum toxin. We can have a spreading of the botulinum toxin into levator palpebral muscle and causing eyelid ptosis, but we can also have spreading to lateral canthus and cause leg ophthalmos, or spread to the lacrimal gland and create a dry eye syndrome. Similar with fillers, we can have a Tyndall effect from incorrect placement. We can have contour irregularities for incorrect decision of the filler rheological properties. And we can also have malar edema just because the patient lymphatic drainage is lower. And this is why every time that I'm coming to patient that is asking for rejuvenation of the periorbital region, this is what crossed my mind. I have bad news, I have worse news. Bad news, we might not help. I might not correctly diagnose the pathogenesis. And worse news, I might have complication. So why am I here today? Because if it's only bad and worse news, so why we are even connecting to this webinar and learning and trying different strategies? And it is because I want to give you confidence. The treatment of the periorbital region might be challenging, but it is possible. And it is possible when you combine different strategies and when you combine different treatment modalities after correct diagnosis. So first, we will go over correct diagnosis, and then we will go over different treatment strategies in order to give you confidence to apply the correct treatment strategy to your patient. We will touch in different treatment modalities. Many of you might not have all of them because, some of us are more treating like more the botulinum toxin, some of us like fillers, some of like energy-based device. We are different, we are individuals, and we have different preference, and it is okay. But I have the privilege to try all of them, so I'm here to tell you what is strong and what is less strong for every indication. And if you have any question about some strategy that I didn't speak during my webinar, you're welcome to write it in the chat. But what is common to different strategies is that I always incorporate cell booster. So if I'm targeting volume loss, yes, I will go through the dermal filler or the PDRN, polynucleotides. If I see fat herniation, I will choose HIFU or monopolar RF. If I see problem in skin quality, I will choose ablative laser, non-ablative laser, semi-ablative laser, thermal mechanical fractional injury. I will incorporate laser-assisted drug delivery with exosomes. I will also incorporate polynucleotide, again, also for the skin quality. And if I see problem in the muscular tonus or high muscular contraction, I will use the botulinum toxins. Sometimes I will use all of them together, sometimes part of them according to my diagnosis, but I will always use cell booster, either cell booster shape, glow, lift, or combination of them. And the reason is because of the chuck technology that I'm sure that most of you already know. The chuck technology is technology that help us to deliver active ingredients in long-lasting release. So the active ingredients are incorporated between the molecules of the HA, which is very big and high molecular weight particle. Thereby, the release of the active ingredients is steady, which help us to target different pathologies, like we'll see later. So if that is clear, we can go and start speak about anatomy and pathophysiology. So we know the skin, we know the different skin layers, the epidermis, the dermis, we know the bone, we don't know the five layers of the face, starting from the skin, then the superficial fat pad, SMAS layer, deep fat pad, and periosteum and bone. But when we are speaking about the eyelids and the periorbital area, we must remember that underneath or posterior to all of these layers, we have the eye globe, and the eyelids have different histological and anatomical correlation. So we can see the anterior layer of the eyelids composed of skin and muscle. And underneath, if we are inside the orbital area, not periorbital, intraorbital area, we can see the orbital septum and the orbital fat, and then the posterior area with the tarsus is something that we are not treating. But we can treat the anterior and the middle layer, and we will see it later according to the pathology. So again, unlike different area in the face that have the 5 layers, in the area of the eyelid and the periorbital area, we sometimes have only 3 layers. We don't have deep fat pad and superficial fat pad, but we have only one fat pad that is underneath the skin and the muscle. So skin, muscle, fat pad, and bone, or skin, muscle, and bone. Sometimes the fat is atrophied, but we are lacking the 2 different fat layers. We need to know it when we are inserting cannula or needle because it have different resistance, as we will see later. What about pathogenesis? So we actually treat the aging of the orbital area or the periorbital area, and the pathogenesis of aging in the periorbital area is quite constant and already known. The first and the most important factor that result in the periorbital aging is, of course, the volume loss. We are losing volume of bone in the area of the in the orbital area of the bone, and we are also losing deep fat bed. And this is why we have this widening, opening of the orbital area. But this is not everything. In addition to the loss of volume, we have pseudo herniation of fat. So the fat inside the orbit that we will see later, the name and the distribution is prolapsing or pseudo herniate in the direction of anterior and inferior. And the reason is because of different anatomical structure that involved in the aging. One of them is, of course, the loss of the volume of the bone, and this is why we have a less resistance in this area. But second is because of decreased collagen and increased laxity in the retaining ligament that we'll see later, and of course in muscle tonus of the orbicularis oculi. All of them together result in this pseudo herniation. The fat is herniated, not real herniation, pseudo, because it does not cross the muscle, but push the muscle anteriorly and inferiorly. On top of all of that, we know skin aging, and the orbital skin is very thin, and this is why it's aged really, really fast and soon. So this is the first skin to age and to have wrinkles and ritids. So all of that together give us the pathogenesis of periorbital aging, and we can address all of them according to the pathology that we see in front of us. So let's start with muscles, because the main muscle that we are treating in the periorbital area is, of course, the orbicularis oculi muscle. The orbicularis oculi muscle, part of it is pressing the skin and the structure into medially, which is the lateral part of it pressing the skin laterally, which is the medial part, some of it pressing the skin inferiorly, the superior part, and some of it pressing the skin superiorly, which is the inferior part. And I'm not stressing it for just no reason. I'm stressing it because we can target it and manipulate the skin wrinkling and the skin textures accordingly. So if I see a lot of wrinkles in the lower eyelid, of course, I can target with botulinum toxin, as we'll see later, this area. If I want to lift the eyebrow, of course, I can target with botulinum toxin the superior part of orbicularis oculi. If I see crow's feet, I can target the lateral part of orbicularis oculi. So I target orbicularis oculi according to the pathology that I see, or according to the location of the wrinkles and the strength of the muscle. But I want you to see and notice one really important key message and key note in the orbicularis oculi muscle. This ultrasound examination checked the location, the depth, and the thickness of the orbicularis oculi. So A is closest to the canthus of the eye, to the lateralmost portion of the eye. B is medially and laterally or medial location to C, and C is the lateralmost location of the orbicularis oculi. When you're going far or lateral from the canthus of the eye, you are getting bigger or thicker muscle that is located deeper. So when you want to target small wrinkles and retids that are close to the canthus, you inject intradermally. And when you want to target the bulk muscle, you need to inject laterally and deep if you really want to be located well. And this diagram showing you how botulinum toxin should be injected according to anatomy. We are sometimes forgetting that anatomy is the base for aesthetic medicine. And we are injecting Botox like, okay, one spot in this area because I see wrinkles, but it's not that. Botulinum toxin should be injected into muscle or muscle fibers that are attaching to the skin. If you really want to target correctly the pathology and if you want to have eye success, you need to inject to the anatomical location. So if I want to target the small retids that are really close to the canthus, I will inject intradermally, like the yellow spot. But if I want to target the bulk region of the orbicularis oculi muscle to open the eye, to decrease the amount of expression and crow's feet, I will inject deeper into the bulk region and laterally in the location where the muscle is the thickest and the deepest. Sometimes I will inject them both, but we need to take it in mind and think about it before we inject, not just inject one point. The depth is really important. So, for example, in this patient, I wanted to target the facial expression. I change the location of the skin, or I flap the skin in order to be below it and really deep and target the muscle. How do I know that I target the muscle? Because I see this swelling. This swelling means that I target a tough organ and not a fat pad that is distributing water very easily. So I am deep and I see swelling. I am in the right location for botulinum toxin for the main bulk part. But if I want to target these small retids, I will create another injecting point more medially, intradermally, as we will see later. So this is regarding botulinum toxin. But let's speak about another important anatomical structure, which are the ligaments or the periorbital ligaments. The periorbital ligaments, sometimes we are taking them as one, we have one ligament, but it is not true. Different ligaments have different parameters and qualities and are completely different anatomical structure. So let's go to the medial part, or number one, which is the tear trough ligament. The tear trough ligament is a true osteocutaneous ligament. The tear trough ligament connects the bone to the skin. There is nothing between the skin to the tear trough ligament. Nothing. Below the tear trough or inferior to the tear trough ligament, we have the orbital part of the orbicularis oculi, and above we have the palpebral part of the orbicularis oculi, but the tear trough is one strong osteocutaneous ligament. It is inserting into the skin. We need to remember it because we cannot expect to inject the filler into the tear trough above the tear trough ligament to mask the tear trough deformity. We will see later what we can do or where we should locate our cannula, but of course not superficial. Then we will get the Tyndall effect, and for sure, because there is no anatomical location for filler distribution in this area. On the contrary, when we are going lateral, we see the orbicularis retaining ligament. And the orbicularis retaining ligament is not one ligament, it's bilaminar ligament, it's two ligaments with fat in between that is responsible for the thickness of the ligament. And this bilaminar ligament is not true retaining ligament because it does not connect the bone to the skin. It's connect the bone to the inferior or to the posterior part of the orbicularis oculi fascia. So between orbicularis oculi to the skin, in the lateral position, we have a superficial location for filler injection. So injecting into two or two orbicularis retaining ligaments superficial is possible and is recommended, but injection of filler medially to the pupil where the tear trough ligament should be deep because we have no anatomical space. It is true retaining ligament, osteocutaneous ligament. The orbicularis retaining ligament is a true retaining ligament, but is not osteocutaneous. It's connecting, like other ligament, the bone to the muscle, like the zygomatic ligament, like the mandibular ligament, like the posterior auricular ligament, but it does not reach the skin. And this is why we can target more superficial layer. When we are going more superiorly to the lateral orbital thickening, the lateral orbital thickening is thickening of this bilaminar layer. It does not have any difference from the orbicularis retaining ligament in the origin, in the insertion, and thereby also in the indication. So bear in mind these two different anatomical properties of these organs. Let's go a bit into fat pads. The first important fat pads that I want you to know and to appreciate is the intraorbital fat pads. We are also calling it the preaponeurotic fat pad. These fat pads are located inside the orbital rim, inside the orbital globe. It's covering the aponeurosis of the eye, and thereby it is protecting it. But sometimes it's herniate, like we saw earlier. So we have five different uh, uh, orbital fat pad, intraorbital fat pad, 1, 2, 3, 4, 5. We're calling them central, medial, and lateral. But in the superior lateral part, we have the lacrimal gland in this location. And these fat pads can be targeted, but they are not getting atrophied. Mostly we don't see atrophy of this intraorbital fat pad, but mostly we see their pseudo herniation. So injecting filler into the orbital area is not really good idea in most cases. We will see later how cell booster shape is covering this gap and help us to target also the intraorbital fat pads. So let's see the extraorbital fat pads, because we know that the intraorbital fat pads are important, but the extraorbital fat pads tend to be atrophied with age. We are speaking about the roof, the retroorbicularis oculi fat pad, the SUF, the suborbicularis oculi fat pad, and the deep malar fat pad. We need to put it into perspective of the retaining ligament, because the retaining ligament is dividing these fat pads. These are deep fat pads, and as they are deep fat pad, they are divided by the retaining ligament, because the retaining ligament is inserting into either skin when we are speaking about the tear trough, or into the fascia of the muscle above it in the layer number 3, or the or layer SMAS, which is all the other like orbicularis retaining ligament. And when we see the location, we understand quite what happened in the eye when we see different locations that being atrophied. So we spoke about the intraorbital fat pads that are pseudo-herniate or bulging out, but the extraorbital area, like the SUF, is the first one to actually being absorbed and atrophied. And this is why this is really good location for injection of filler. But if you want to inject a filler into the SUF, you need to make sure that you are not above the orbicularis retaining ligament or the zygomatic ligament, and you are above the zygomatic cutaneous ligament. So again, if I want to inject correctly the SUF for being atrophied or for atrophy of the SUF, for hollowness, for shallow location, then I will inject the SUF deep beneath the tear trough or the orbicularis retaining ligament and above the zygomatic cutaneous ligament. Some tips that will help me to achieve that is first to have a right location of insertion of cannula, and second resistance, and we will see it later. So again, pseudo bulging or pseudo herniation of the intraorbital fat pad and atrophy of the extraorbital fat pad, like the SUF between the tear trough or the orbicularis retaining ligament to zygomatic cutaneous ligament, or the deep malar fat pad that can be found beneath the zygomatic cutaneous ligament, which is also being atrophied very, very early in early age. Similar with the roof, but the roof is a bit more complicated, and I will leave it out of this session. But what happened? So with age, we spoke about the retaining ligament. They cannot really hold all the fat that is pseudo-herniate. It doesn't matter how strong they are, they cannot do it, because the aging or the decreased collagen is much, much faster. So we either get this bulging from pseudoherniation due to weakening of the muscle and the retaining ligament, or we get this atrophy from volume loss of the underneath layer, the SUF and the deep malar fat pad. We need always to check it before we decide. And one way to check if we have volume loss or pseudoherniation or combination is to see if the location of the atrophy is really homogeneous distributed or not. If pseudoherniation occur, then we can see it all over the inferior eyelid, because the herniation is homogeneous. Not part of the muscle is getting weak and part is strong. No, all the muscle and all the ligament is getting weak and more lax. This is why we see more homogeneous distribution of this bulging or hollowness. How you want to call it, it doesn't matter, but it is because of pseudoherniation. On the contrary, if we see volume loss, the distribution of the hollowness is not homogeneous. So maybe the lateral part will be okay and the medial part will be atrophied, or the opposite, it doesn't matter, but it is not homogeneous because volume loss is not homogeneous distributed. So it might be that we have both of them, but the targeting is different. If I want to target volume loss, I will target it with filler. So as I said earlier, we have different insertion point for the cannula. I inject only with cannula fillers in the periorbital area, but of course, every one of you have their own experience. So injecting the hollowness in the area of the tear trough, if we want to inject deep into the SUF, extraorbital, above the zygomatic ligament and below the orbicularis retaining ligament, we have the insertion point in the lateral part of the pupil, and then we are inserting the cannula and getting into the direct location. We have nothing there. As we said earlier, the skin is connected to the tear trough ligament. This is why if we are getting below the ORL, above the zygomatic cutaneous ligament, and with an angle and direction to the location of the upper part in the medial part of the SUF, then we will be there. We have no other place to reach unless we are piercing the tear trough ligament, which I recommend you not to do. So if you feel high resistance, do not cross it. What about grooves? What about hollowness in the area of the lateral SUF? So if I see hollowness in the place of the lateral SUF, I will get into more lateral location of the insertion point. So lateral pupil is my medial insertion point for hollowness of the medial SUF beneath the tear trough ligament. Lateral location is when I want to fill all the SUF when I have all SUF atrophy. And what is droplet technique? Droplet technique is to fix the prolapse by strengthening the tear trough ligament. But as I told you, my recommendation and my practice does not involve filler injection into this spot, but cell booster shape, as we'll see later. So if I see pseudoherniation and not volume atrophy, the go-to that I recommend to you is, of course, tightening. For this indication, I use dual frequency monopolar RF. And the reason that I use the monopolar RF dual frequency to this location is because I want to target the area or the ligament and the muscle in this location. And if I want to target both retaining ligament, ORL, tear trough ligament, and the muscle, the orbicularis oculi in this location, I need to have the correct angle, but I need to have the correct frequency, because 6.78 megahertz with monopolar RF is good for skin and retinacular cutis, and it will be good for the part of the tear trough because it is connected to the skin. But if I want to target the orbicularis retaining ligament and the orbicularis oris muscle, then I need to add also 2 megahertz. And this is why for the periorbital region, I prefer to use dual frequency monopolar RF, non-invasive, of course, to target both of them. And then I target both muscle and retaining ligament for strengthening the fat. I can also combine HIFU because HIFU In addition to the decreased subcutaneous fat thickness, it can decrease the subcutaneous fat thickness in the intra and extraorbital fat bed. It also increases apoptosis and autophagy and also result in muscle contraction in these locations. The only difference is that with monopolar RF, I am sure that I am in the correct spot, and with HIFU, sometimes I miss because I cannot target all layers. I need to choose one location. It's either I target or I am not. And this is why, in my preference, is the monopolar RF, but of course you can use HIFU or combine them. So let's discuss a bit about the combination of cell booster, because for fat, either for fat loss, atrophy, like in the SUF, or for fat pseudoherniation, like in the intraorbital fat bed, L-carnitine should be injected. And the reason is because L-carnitine stimulates lipolysis. Some of the things that occur with aging is decreased mitochondrial function, decreased ability of mitochondria to dissolve fat or to use fat in the fat layer, and this is why it's getting hypertrophied. And when we have hypertrophied on weak structure on or weak anatomical structure that they cannot hold the fat bed, then it herniate or atrophied fast. And this is why L-carnitine should be injected. Cell booster shape contain L-carnitine, and this is why it is my go-to, either in fat atrophy to the SUF or in pseudo-fat herniation in the intraorbital fat bed. Similarly, vitamin C is also a very important part to be injected because it stimulates the lipolysis and reverse the accumulation of adipocytes. And this is why vitamin C and L-carnitine together should be injected in any occasion of aging of fat layers. So either in atrophy or in pseudo herniation. We already proved it. We published in last IMCAS a scientific poster that show that the skin subcutaneous tissue where the fat bed, the superficial fat bed is located, change both the thickness and the structure. And my injecting technique is very easy. I'm using, as you see, a big gauge needle, 27 gauge, because I do not want to target the skin. I want to target the fat bed. I am inserting the needle only the tip of it, maybe 1 to 2 millimeter, and I'm injecting into the intraorbital fat bed cell booster shape. I'm using an angle of 45 degree because again, I don't want to target the skin with a cell booster shape. I want to target the intraorbital fat bed that are prolapsing. On the contrary, when I want to use the cell booster shape for the SUF atrophy to this for the SUF layer, then I'm using cannula. And the reason is because the SUF is much bigger and it's much easier to be targeted with cannula. I'm not always using ultrasound. This ultrasound was only to show you the location of injection, which is actually quite superficial in the area of the SUF. So it's not a superficial fat bed, it is deep fat bed, but I am not reaching on the bone. I am a bit more superficial to target not only the fat bed, but also the edema, because cell booster shape is increasing resorption of edema. And this is why we see change not only in the size, but also in the consistency. We increase collagen amount in the fibers that protect the fat bed and position them in better location. So even if we see a lower or thinner area, the position and the strength of the fat bed is much better. Do not forget that it's different between someone which is laying down or standing, and the position of the fat bed is more important than its thickness. And we proved it in few patients, of course, not in one, both with the live vis and of course with ultrasound. But what we are doing with skin, so we understood targeting the retaining ligament and the orbicularis oculi muscle, we can do it with monopolar RF or HIFU. Targeting the fat bed, we can do it with fillers and with cell booster shape. But how can we reverse skin aging? How can we go into a better state of skin and that will look also better? So first, we need to speak about the pathogenesis and the mechanism of skin aging. primarily intrinsic aging, because with intrinsic aging, we have senescence of fibroblast. But what does it mean, senescence of fibroblast? Fibroblast senescence mean decreased integrin receptors and TGF-beta synthesis in the area of fibroblasts. And this is why we have decreased amount of production of collagen and elastin, of course, and this is why we have low strength. Normally, our body would be able to just manipulate the tissue or to remove these senescent fibroblasts with macrophages. But our fibroblasts are very smart, and the senescent fibroblasts are aged, so they are even smarter. So they possess the CD47 receptor, which is the do not eat me signal of the macrophages, and this is why they're getting accumulated. In addition to that, we have the extrinsic aging that overburden macrophages and increase the amount of reactive oxygen species and cytokines that are inflammatory. So we have chronic inflammation together with senescence. As a result, of course, we have decreased regulation. The problem is not only the amount of collagen and elastin, but their position, their location, and their folding because of the decreased, dramatically decreased amount of extracellular matrix regulator proteins. And this is interconnected to the amount of reactive oxygen species. When we have more reactive oxygen species, we have more aging of the skin, and this is why we want to reverse it. We want to decrease amount of reactive oxygen species, increase amount of modulators or remodulators in the skin in order to strengthen it. We can do it with hyaluronic acid. Hyaluronic acid injected intradermally create pressure on the mechanical pressure on the fibroblast, thereby stimulating the production of collagen and elastin. Cell Booster Lift is my go-to for periorbital skin rejuvenation because I inject it intradermally and it is containing high amount of big molecule of hyaluronic acid, creating pressure. So again, when you want to rejuvenate the skin, do not inject with cannula and do not inject underneath the skin, inject into the skin because hyaluronic acid create pressure on mechanical pressure on fibroblasts, thereby stimulate their biosynthesis capacity. Together with that, when we inject the hyaluronic acid into the skin, we also biochemically activate fibroblasts. So not only mechanical, some receptors like CD44 are receptors that connect to the amount or depend on the amount of hyaluronic acid that can be found in the skin and thereby stimulating fibroblast. So it is very important note because I saw many people and many different key opinion leaders there. I have a lot of respect to them, but in my perspective, according to the biological mechanism of hyaluronic acid in the skin, if you want to rejuvenate, especially the periorbital, but not only the periorbital skin, you need to inject Cell Booster Lift intradermally because you want mechanical pressure and you want biomechanical activation. But the secret of Cell Booster Lift is far behind hyaluronic acid because we have other products with hyaluronic acid. The secret of Cell Booster Lift is their incorporation of active ingredients. So we are not getting only biochemical activation and mechanical pressure. We are also gaining amino acids that are maintaining cellular function. We said part of the aging of the skin, especially in the periorbital part, but not only, is dependent on the amount of regulators. One important regulator is arginine, and if we will not have enough supply of arginine, of course we will not have collagen deposition because we will not have correct laying of collagen, not only production. You need to lay it properly. You need to put it in the location when it's creating the highest effect. And this can be done by continuous supply of arginine. Similarly, we discussed TGF-beta synthesis. With aging, TGF-beta synthesis decrease. If you want to inject substance that increase TGF-beta synthesis, what you really want is arginine because this is the building block and the maintaining function of the cells in the skin. Similarly, Cell booster leaf contain other regulators like glycine and proline, which is regulating endoplasmatic reticulum synthesis of collagen, lysine and vitamin C, which are regulating the exocytosis and the assembly and cross-linking of collagen. Again, not only synthesis, regulation. The problem with aging is regulation. So if you want to regulate, you need to add regulators like glycine, lysine, proline, vitamin C, and arginine. So with Cell Booster Leaf, you have all of them in one product. You inject hyaluronic acid and regulators into the skin with the Chuck technology. It's long lasting, and this is why it is my go-to. Of course, it also has vitamin E and vitamin C that decrease reactive oxygen species, which make it even better for the skin, especially in the periorbital area. So I will start with botulinum toxin injection, like I showed you earlier, into the muscle. And then I will go to injection of cell booster lift. And notice that I'm injecting with much thinner needle, the invisible needle 33 gauge. I am inserting 1 millimeter, 45 degrees angles, and creating this intradermal injection. This is the same location where I will inject botulinum toxin, but not only not in the medial part, only in the lateral part, but I mean in the layering position. So intradermal injection can be of botulinum toxin for the muscle in the location of medial location, not lateral location, or and cell booster lift into the skin. Again, 45-degree angle, invisible needle, 1 to 2 millimeter depth into the skin, seeing bulging, this bulbing of cell booster lift for rejuvenation of the skin. But sometimes I see not only wrinkles and retids in the skin, I see pigmentation. And when I want to target pigmentation, I need my two important helpers for decreasing pigmentation production, which are glutathione and cysteine. Because glutathione is not only powerful antioxidant, glutathione also involved in pheomelanin synthesis together and inhibit tyrosinase activity. But together with it, that cysteine is a gating part of gating amino acid for pheomelanin. So when I inject glutathione and cysteine together, I am gating the melanin to become pheomelanin, which is much brighter, and decrease the amount of tyrosinase of melanin synthesis, thereby decrease pigmentation. So again, Botox is the primarily and the first one to inject because it's the deepest from all of the product that I inject on the without relation to filler, and then I inject Cell Booster Glow with glutathione and cysteine. Notice that I'm using the same needle, the invisible needle, but I'm using much higher angle for injection. So no 45, but more closely to 180 or 130 degree in order to reach to the uppermost layer of the dermis, the papillary dermis, which found below the basement membrane where the melanocytes are existing. So the only thing that I change is my angle. When I'm injecting Cell Booster Lift, I'm 45-degree angle. When I'm injecting Cell Booster Glow, I'm 130-degree angle, almost parallel to the skin. To that, I am adding energy-based device because only energy-based device can create enough stimulation for remodeling and assisted drug delivery to combine this effect. I want skin remodeling. For me, it is not enough to just inject active ingredients. I want to stimulate the skin for new collagen synthesis, and I'm doing it either with non-ablative laser or semi-ablative laser or TMFI, which are approved by FDA to work on the eyelid, even on the eyelid themselves in the periorbital area. I am getting remodeling, I'm getting balancing of pigmentation, and of course, I can also help it to deliver drugs. So I'm using it for assisted drug delivery. Either TMFI, 1515 erbium glass, 9027 thulium, and if the Fitzpatrick is very low and very bright patient, then I can also use my ablative laser. So this is the beginning of experiencing different things or different products that can be added after energy-based device and together with injectables for comprehensive rejuvenation. One of them is the exosomes, of course, that are just growth factors that are located inside extracellular vesicles that are secreted by human mesenchymal bone marrow stem cells and thereby create high amount of growth factors to decrease inflammation and to stimulate regeneration by stimulation. And the exosomes are, of course, containing growth factor and microRNA, messenger RNA, and this is why they are not legal, not in Europe and also not in Israel. We are using biosomes or controlled synthetic exosome. Synthetic Synthetic exosomes are not only controllable, they are also predictable and specific. And this is why using synthetic exosomes is so important in the rejuvenation process and the change of the tissue. I'm applying them after energy-based device, after I created some channels in order to stimulate regeneration and change cellular behavior. Polynucleotide are another way to rejuvenate the tissue and to support energy-based device and other injectables. It has three different mechanisms of action: adenosine 2 receptor stimulation that increase CAM production, thereby stimulate production of NFK beta. We have also the salvage pathway from purine and pyrimidine salvage from the polynucleotide, thereby further stimulating synthesis, migration, and healing of cells. And of course, when we are speaking about polynucleotides and not PDRN, we also have scaffolding structure for volume and for maintenance of this periorbital area. And when we want to combine or to compare polynucleotide with hyaluronic acid, what we see is very, very nice. We see that the dermal density and elasticity is similar, but polynucleotides are better changing the skin roughness and pore volume. So pore volume and skin roughness are more affected by polynucleotides when compared to hyaluronic acid. But combination of hyaluronic acid and polynucleotides creating synergism and the best high yield effect. My technique is similar. I can use needle like I used to inject the cell booster, or I can use cannula to target larger area. Usually, I'm using cannula for volume, for scaffolding with polynucleotides, and cannula for skin texture, roughness, and pore, together, of course, with the other modalities that we mentioned. And with comprehensive treatment, we can change not only the color, the texture, the pores, the wrinkles. We create much beautiful and much more homogeneous and young periorbital area. But my last key message to you is to not wait. Because when you wait for blepharoptosis and dermatochalasis, which is an increased amount of skin and lax skin, both in the upper and the lower eyelid, I don't think that anything in the energy-based device or injectable spectrum can help. Surgery is the only way to target this patient. And this is why, for me, rejuvenation of the eye area or the periorbital area does not mean waiting them for aging. I'm starting periorbital rejuvenation with cell booster, shape, lift, and glow, energy-based device, fillers, botulinum toxin, PDRN, exosomes, all of that. I start very, very early because this skin is getting aged the earliest. And these fat pads getting prolapsed the earliest, and this muscles tone is getting different or change according to the location earliest. And these are my take-home message. So start early, select the targeting according to the pathology. So target fat herniation with high for monopolar RF, target volume loss with dermal filler or PDRN, target muscular tone with botulinum toxin, and target skin quality with energy-based device, PDRN, and exosomes, but always, always, always add cell booster, shape, glow, lift according to the indication, combine them or decide and inject them to the correct location. So I hope you find it interesting, and I am now available for answering your questions. So I will go to the chat. We have 10 minutes. Great. Oh, I don't see any questions. So if you have any questions, you are welcome to write it now. And if not, we will end this session. Ah, okay, I see it. So first question was, what about vascular dangerous area around the eye? So vascular areas around the eyes are mainly in the infraorbital foramen. When you inject with cannula deep and with needle only superficial intradermal, you probably will not compromise them. This is why I said that I use only cannula for deep injection if I want to target even the SUF. When I want to target with cell booster shape, I will use only cannula. And when I'm injecting with needle, I will inject intradermally, with the exception of the intraorbital fat pad, that the only way to reach them is with needle. You cannot really inject them with cannula, and you need to do it very carefully. But the highest vascular location is the infraorbital foramen, which in this location I recommend not to use needles in order to not damage them, not only for blockage. So vascular compromise is not my only fear. The other fear that I have is piercing them and causing a big hematoma, which can do one of two things. One, it can cause compression on the vascular or on the eye ball. But second, it can cause pigmentation and post-inflammatory hyperpigmentation, erythema, and changing on skin texture because of hemosiderin deposition. And this is why I am taking care not to manipulate them. Do you apply the energy-based device treatment after the product or before? So it is a very good question. And of course, it depends on the location. And if I injected, for example, a cell booster with cannula or not. So if I injected with cannula for the deep fat pad, it doesn't matter. I can do it before or after. But if I am performing heat energy-based device with heat, not microneedling, so then I will do it before and not after, to avoid eating the product itself. Not because I think that it is so dangerous, but it can compromise the function or the effect of the cell booster and other ingredients. So before. When combining exosome therapy, mesotherapy, and energy-based device, how do you determine the ideal timing, session planning, and sequence of applications? So this is also a very nice question and very important to note, because it's different between different practitioners. In my clinic, sometimes patients are coming from far to get treated, and they are driving 2 hours, 3 hours to get into my clinic. And this is why I cannot separate session. I need to combine as much as possible. And then I am working from the deepest, most area to the most superficial, in order to not damage any product placement or energy-based device. So I will start with a deep energy-based device like monopolar RF or HIFU. Then I will add botulinum toxin or everything that is injected into the deep, so fillers, botulinum toxin, and then I will finish with injection of mesotherapy and application of exosomes, of course, in the end, because it is the most superficial. The session, so we will have one comprehensive long session, and then the difference between the interval between session will be according to the energy-based device. So if the energy-based device is letting me to perform treatment with short interval, like microneedling, for example, then I will have a short interval of 2 to 3 weeks. But if I have an energy-based device that is requiring longer lasting, like ablative laser, non-ablative laser, and of course monopolar RF and HIFU, then my schedule will be 1.5 months. Regarding your poster in IMCAS, why you use HIFU besides cell booster shape? So the reason that I use HIFU together with cell booster shape is because of their synergism. If I know that HIFU increase autophagy, increase TGF-beta synthesis, and create collagen contraction, and cell booster shape is manipulating adipocytes to behave better and to absorb the fat better, then their combination is synergistic, and this is why I use them both. I mostly use combination therapy. So energy-based device for me are very important in the treatment, and cell booster shape for me is synergistic to energy-based device in fat layer maintenance. Cannula used under muscle and needle intradermally. So yeah, exactly like that. Cannula used when I want to work underneath the SMAS layer, underneath the muscle, underneath orbicularis retaining ligament, underneath orbicularis oris oculi, and of course when I want to inject intradermally, so only needle, because cannula cannot inject intradermally. How about mixing different cell booster product in the same session? Definitely, definitely, definitely. I am doing it very, very, very commonly, because I like the effect of cell booster lift the most for rejuvenation, cell booster shape the most for fat rejuvenation, and cell booster glow if there is some darkening. What I don't mix a lot is glow with lift, because for me, if I have pigmentation, I decide glow. If I don't have pigmentation, I decide lift, and I am combining it usually with shape, especially in the periorbital area. Is shape can be placed deep in the SUF? Of course, I am doing it. I'm doing it because when we are discussing cell booster shape in the periorbital area and in the fat pad, what cell booster shape is doing is not lipolysis, and it's not destruction of fat. It is rejuvenation of fat. So if fat is getting atrophied, rejuvenation of fat means hypertrophy or stimulation of new layer synthesis with collagen or new septors, and better location of the fat pad. And if we see prolapse or hypertrophy of fat, then of course rejuvenation mean a decrease or atrophy of the hypertrophied adipocyte. So for me, it is not a lipolytic or filler or anything else. It is special product that help me to rejuvenate fat, no matter what the indication, but I inject it according to the pathogenesis. Which PDRN would you recommend? I think that I'm not allowed to answer this in this session, sorry. Or just on the fat, so I think it's connected to the last question. Maximum amount of lipolytic for fat under eye. So amount of lipolysis is dependent on our own body. Do not forget the cell booster shape is a rejuvenator of fat. It is not lipolytic agent. And I don't think that if you will inject a lot of product, you will get better lipolytic and effect, or less product, you will have more lipolytic effect. You need to inject the right amount of product to just distribute it homogeneously in all locations. So it depends on the amount of skin and or the size of the periorbital area of the patient. But usually I inject the small papules of 0.01 to 0.02 in every 0.5 centimeters. So until I reach all of the location. So thank you. Do inject shape inside the fat pad. So because I'm not using always my ultrasounds, sometimes I don't know if I'm in the correct location and I'm exactly in the fat pad, but I'm trying to be inside the fat pad according to the anatomical location that I guess that I will find it there. So I'm trying, and I think that mostly I succeed because of the anatomical knowledge. If you want, you can use your ultrasound to make it even better, like I showed with the SUF. And I think that we have last minute for last question. What is the protocol for eye area? And can you mix cell booster, for example, shape in the first two sessions and later lift? Definitely. Again, pathology and correct diagnosis. If the main problem of the periorbital area is pigmentation and skin quality, I will attack it first and I will start with it. If the main problem is prolapse or atrophy, I will start with it first. If I cannot combine it in the same session, and if I can, I will target them both. So of course, I am mixing in the same or in different session, but the timing of the treatment, as I said earlier, depends on the energy-based device. If I do not mix energy-based device, then my injection will be every 2 to 3 weeks. So I think that we don't have time anymore, and I think that I will be able to answer these questions later on. Thank you very much for being here with us, and I hope that I I was managing it correctly and helped you to learn some new stuff about the periorbital area.